just
all
announced
coming
that.
back up
Yeah.
at the end. Okay, got it.
They'll come.
Good afternoon. Thank you all for joining us. My name is Andrea Fairman. I'm an associate professor up at MGH Institute of Health Professions in Boston, but I actually work very closely with a number of the persons that are going to be presenting on this panel and talking about mobile health as well as accessibility of mobile health. I'm not going to say a lot because I am the moderator and that's not my role in this particular talk, and also because I'm talking later and I don't want to use up all the things I might say later on in being moderator for this one. But one thing I do want to ask you and actually kind of include you in this conversation is the term empowerment. What does empowerment mean? And how are we going to actually implement mobile health to empower persons? And not just persons with disabilities, but all persons. So what are some terms that come to mind when you hear the word empowerment? What does that mean to you? Being independent, so being able to do things for yourself. Respect. Respect is, I think, very important. Choice, having choices. Having control. Being the owner of your own health care, right? So all of these kinds of things are becoming increasingly possible with what we're able to offer persons in using mobile health applications. And so I just want you to kind of keep that in the back of your mind as we're listening to our various presenters today. And we're going to start off with Ryan Nussbaum. Am I saying your last name correctly, Ryan? So if you'd like to come up and join us, please. And we're a little bit behind on time because the other award ceremony letting out a bit early, so we'll just try to keep it moving pretty quickly here.
Sure. All right. Is that working pretty well? All right.
Very closer.
A little closer. Okay. All right, so thanks for the intro. My name is Ryan. I'm a physical medicine and rehab resident in my second year. And let's see here, maybe, there we go. And I had the privilege of working with Dr. DiCiano and Dr. Parmanto from UPMC from 2016 upwards till, actually we're still working on it. So for the last 2 years, we've been collaborating on a project that has to do with mobile apps and rehab in general. So we just wanted to share some of the information from that project. So learning objectives for today, as I already said, we're going to go over the systematic review, which looks at mobile apps used in rehab. And particularly, we'll look at the mHealth or mobile health apps, and we'll touch on that if that's not familiar with some people. So again, title, Systematic Review of Mobile Health Apps. And our question was, essentially, what have we been doing with apps in relation to physical medicine and rehab and their applicability and their use? So we actually looked at studies from a 10-year period from 2006 to 2016. And currently we have the manuscript submitted to American Congress of Rehab Medicine, and we're going through our second edit. So we're hoping it gets published soon. So the inclusion-exclusion criteria, it's pretty intuitive, but to be included, it had to be an app, and it had to be on a mobile phone, a tablet, or an even PDA. We saw a few different PDAs in the studies from the early 2006 to 2010. And it has to be a software app that's looking at a rehab-related topic. Exclusion criteria, if it's not rehab-related, if it was using a computer, if it was directly telemedicine, we excluded it. If it was design and development, thesis or dissertation, research protocol without results, and if it was case study or case series, we excluded it. So this is a pretty busy slide here. Let's see. I can just explain the important stuff. So basically, we looked through 8,000 different abstracts. The search engines we used were PubMed, IEEE, ACMDig, Scopus, InSpec, and Embase. And we just looked at abstracts. It was a medical student, and I was in med school at the time, so it was a lot of work. We could have used some robotic learning or some machine learning. It would have been helpful. It sounds like that's on its way or may already be present, but we basically went through all those, and through the abstracts, we got down to 597 studies. We reviewed those from beginning to end, and we came down to 102 different studies. So of those, study design-wise, 41 were validation, 23 were usability. Cohort, there was 24, and randomized controlled trial, there was 9 of those. So this is how Dr. Parmanto, Dr. DiCiano, they categorized apps in a unique way through their prior research. And so basically, this is how we did in this study as well. So we had 102 studies, and we categorized them into these 4. And so lifestyle-oriented apps, you can just think of like Fitbit, so anything that the user is solely using for weight loss or diet or to try to do more exercise. Patient-oriented app is looking at, there's no clinician involved. It's more of the, I think a good example, like if a patient had diabetes, the whole app would be catered towards treating that condition from a chronic perspective. So giving medication updates, letting them know, asking surveys for certain symptoms that could be concerning for the disease getting worse. And then clinician-oriented app, that has more to do with, if you think, whatever would help that clinician. So if it's like a particular measurement tool or using any sort of, really just to provide information to the clinician, maybe to refresh on the disease process. And then mHealth system, that has to do with basically, it's similar to telehealth, but the difference is that it's going to be used on a tablet, or it's going to be used on an iPhone or any sort of cell phone. There is communication between the clinician and the patient, but it doesn't have to be in live time. For instance, if there's no Wi-Fi connection, the patient can put in information related to whatever condition we're monitoring, and then once the Wi-Fi comes back, it can be sent to the care team. Does MD Live fit in there something? I'm not familiar with MD Live. I'll have to, okay. Yeah. Okay, gotcha. So these were the variables of interest we looked at. So the technology used, or the name of the app, the type of app, the purpose of it, study design, participants, randomization, blinding, outcome measures, results, the conclusions, and the completeness of data and bias. And there's a lot going on in this slide, but it just cut to the functionalities that we thought were particularly interesting. For a connection to electronic health record, 0 of the 102 studies had that capability. And then from a HIPAA compliance standpoint, 5 of the 102 studies demonstrated that. So just something that we thought was pretty interesting. But again, we looked at certain things such as gamification, goal setting, medication management, reminders, secure messaging, photos, and that can be, we can talk about that at a later time. So this is the important thing here. We're looking at mHealth systems, particularly for this talk. So the top is the study design, so cohort, cross-sectional, randomized control, and then the bottom is, or on this, excuse me, the vertical column, that has to do with the type of app. So the thing to note there is that for the most part, cohort was the most common study design for mHealth apps with 12. There was 8 that were usability, there was 5 that had validation, 3 with accessibility, and 5 with randomized controlled trial. And just I think that the low number of randomized controlled trial is what the main point we were trying to get across. And this is, in general, we categorize the studies based on these subject matters, so neurologic, stroke, general, measurement tools, cardiac, musculoskeletal, pulmonary, TBI, spinal cord, pain, and cancer. So in the research, we actually made tables where there's specific descriptions of each of these apps, and they're categorized in this manner. And large conclusions from this review. So we looked at all the different studies. 1/3 of those studies actually was looking at the app as an intervention. And in contrast, 2/3 of them were just looking at the functioning of the app or participant interaction with the app. And then we did see positive benefits when it came to these apps being self-management systems, delivering exercise or gait training, and then measurement tools as well. So at this time, I'm just going to run through a few of the examples, particularly looking at the mHealth system type of apps, and just to provide some may be familiar with some of the apps. So this was an app called Arm Strokes. So the purpose of this is the lead author was Jin, and if I'm saying these names wrong, I apologize in advance. The lead author was Jin Guo, publication year 2015. It was an accessibility study that was focusing on improving arm function in individuals who had a stroke with a strength deficit. So it was using essentially the inherent sensors in the phone, inherent audio and haptic feedback, and it was a gamification type like technique. So kind of go into it a little bit more. So given that it was an accessibility, users found the app pretty easy to use, even after training with just 10 minutes. And they thought that their feedback in general was positive. And I would show a video, but we're just a little short on time. But if you just Google Arm Strokes app, they have a website where they're actively looking for participants. This is not available on iTunes. It's not available in any app stores at this point. But they do have videos of how it is used and things of that nature. The next one is called mCare Application. It's focused on the population that was in the military that had experienced a traumatic brain injury or PTSD. Lead author was Holly Pavlicek, and this was a randomized controlled trial. So the purpose of this app was essentially to help these population get back into civilian life. So it was a two-way communication system with a care provider where they would send health tips, they would give appointment reminders and daily questionnaires kind of about how they're doing, their memory function, just their anxiety, stress, things of that nature. And their findings from this, they were looking particularly at adherence, engagement, how often were they actually completing the questionnaires, things of that nature. They saw a sustained response in these individuals using it, the app, regardless of their health status. So, and this, I couldn't find this when I looked on the internet for public awareness or public utilization, but I believe they're still using it in the military. So this next study is called, or app is called Cognitrack. This was focusing on cognitive function in individuals who have multiple sclerosis. The lead author was Dr. Andrea Ticino. This cohort study basically was an app that the individual would have at home where they would complete working memory function tasks. And so the thought there was, can we improve this in some regard by them using it at home? And then it was remotely monitored by the clinician or healthcare provider. So looking at adherence engagement, questionnaires, they had an adherence rate of 84%, had a good understanding of the instructions, and they felt independent using the app. So it was in general well accepted. This next app is looking at aphasia rehabilitation. It's called Constant Therapy. The lead author was Carrie Desroches. This was a cohort study looking, so essentially the purpose of it was they had 37 therapy tasks that could be provided through mHealth, and it was looking to improve language cognitive therapy. So they were looking at speech improvement, adherence, and engagement. So in general, they saw that both the intervention and the control groups demonstrated improvements in their ability to speak and to understand. And they saw on the standardized testing as well. So this app is actually offered online right now. They have a pretty impressive website, and people can just jump on and use this. And it was just constanttherapy.com. So Cloud Rehab was another application. This was used for rehabilitation motor exercises for patients with traumatic brain injury. So the lead author was Angel Ruiz Zafra. This was a cohort study, and this was essentially working on different like occupational therapy tasks, physical therapy tasks. They were just being able to monitor an individual do tasks at home. And then there also was utilization of like a heart rate monitor and for particular tasks as well. So they were looking particularly at the functionality the adherence engagement and usability. They saw in general that there was an improvement in target behavior compared to baseline status, and the user satisfaction was 3.75 out of 5. So this app is, I believe it's based out of Spain. They have a website, Cloud Rehab, and these were pictures from their video, essentially showing that the phone was attached to some sort of apparatus. It's filming the gentleman cut his food up, and then he's receiving feedback from a care provider explaining them kind of how they're doing or things of that nature. So the next app is called I'm Here. This is an app actually created by the UPMC group supporting self-management and service for participants with spina bifida. There's a handful of lead authors. It depends on which study you'd look at, but this one in particular was Dr. DiCiano, randomized controlled trial that Dr. DiCiano's next speech is, he's going to be touching on this app for the most part, so I won't say much, but there was statistical significance with improvement in the functional, medical, and behavioral areas of this population. So in conclusion, there's an increasing amount of evidence showing that mHealth as well as additional apps are effective for improving the function of various populations in rehabilitation. But there still is a need for more randomized controlled trials. And in particular, for the mHealth apps, there needs to be more of a evaluation of how this can be incorporated into a value-based care model with multiple stakeholders at place. And then we already touched on HIPAA compliance and connection to EHR as 2 areas of improvement as well. So that's it.
Okay, so for the next talk, as Ryan just mentioned, Dr. Brad DiCiano is going to give an overview of the I'm Here system, which has been tested on multiple populations and continues to be developed.
Thanks, Andy. Good afternoon, everybody. I'm going to start off with a real patient case, just as an example. One of the things I do is I'm a rehabilitation physician. I run the adult spina bifida clinic at UPMC. And some of the initial ideas that we got for developing this mobile health system came from real problems that we see in our patients. So we'll call this patient Lisa. She's a 40-year-old. She had spina bifida. She also had hydrocephalus. And she struggled with severe wounds. She had lots of pressure ulcers. She used a wheelchair. Her medical costs were very high, both her total medical costs and also her costs of what we think are probably preventable conditions. And she used the emergency room quite a lot, not only for her wounds, but also for minor things. Whenever she would get a cold or different types of upper respiratory symptoms, she would go to the ER even for that. So she wasn't really utilizing the system in the appropriate way. And we partnered with the Spina Bifida Association of Western Pennsylvania, also UPMC Health Plan, and we piloted some projects where we used a mobile nurse case manager to do more intensive case management and preventative care with our patients, and saw some promising results. But what we realized was that program wasn't really scalable to the amount that we needed. Our patients live far away. The nurse was only able to drive out to their homes and handle so many subjects at one time. So we decided to develop a mobile health system. A lot of our patients were very tech savvy, and we thought, why not try to deliver some of these interventions through a mobile health-based system? And some of this initial work was Dr. Fairman's dissertation work at Pitt. So we call our system the Interactive Mobile Health and Rehabilitation System, or I'm Here. And what you're seeing on this slide is version 1.0. This was the first iteration that we came up with. And this was a very medically based mobile health system. And what it was a smartphone app that had different modules within it. And the modules allowed the patients to manage some of these preventable conditions that we wanted to target. And it linked to a web-based portal, which a clinician in our clinic could theoretically monitor. In this case, the person monitoring the portal was Andrea as an OT. And the portal allowed the person monitoring it to triage what was going on. So they could quickly see the patients that they were following and the problems that they were reporting. And so some of the features, the system offered reminders to do things like take meds or check the skin, report symptoms. So if they had symptoms of a UTI, for example, they could tell us. Flow sheets to track problems like the amount of incontinence they were having. Surveys to ask them questions about things like mood, photo uploads. So this was really helpful for us to see pictures of their wounds and follow them over time. And then securely message us in the clinic back and forth. And we had modules specifically for bowel management, bladder management, skin integrity, mood, and medications, because those were the areas that we thought were high priority and ones that we used in our in-person based system. So we actually conducted a small pilot randomized controlled trial, just looking at the feasibility of this system. So we followed people for a year. We took 23 people, randomized them. The intervention group got regular care and the mobile health system. The control group just got regular care. And we wanted to see if people would use the system according to what benchmarks we predicted. Would they use the system over a year period? Would they get tired of it? Whether they might have fewer preventable conditions or improvements in different medical and functional outcomes. So after randomization and exclusion, we had 13 people in the intervention group, 10 people in the control group. The groups were statistically similar in terms of background and demographics. And some of the key findings from this study, if you look at the graph, the bars on the top in the light blue show the control group. Those people, on average over a year period per person, either stayed the same or got worse in terms of preventable conditions and hospitalizations and ER visits. Whereas the persons in the intervention group improved in all 7 of those areas. Now because this was a small cohort, these were all trends. They weren't statistically significant, but they were consistent across all 7 areas. We also thought that the system showed feasibility because people did use the system and continue to use it over a year period. They used several features pretty frequently, sometimes even more than we expected. There were a couple areas that fell below our benchmarks that were reminders to do their self-catheterization and check their skin. But for the most part, the other features were utilized quite heavily. We did look at those who used the system more often than those who used the system less often. And the high users showed improvement in their self-management skill and also less reliance on caregiver assistance. We did an estimated cost savings from the medical changes that we saw just in the inpatient utilization, and we estimated an average of about $27,000 per patient per year using the system in cost savings. And when we looked at receptivity of the system and satisfaction, that was also very high on the part of patient, family members, clinicians. And so we felt that we targeted several areas of what we call the triple aim, where we're looking at improvements in health outcomes, improvements in experience of care, and reducing cost. And in terms of Lisa, she actually completely improved. She ended up by randomization in our intervention group. She used the system, and by the end of the study, her wounds were completely healed, and she actually stopped using the ER also for some of those minor issues that didn't require ER visits. So we wanted to continue this work. We also piloted I'm Here 1.0 in the spinal cord injury population. And this paper we're still writing up. We randomized 38 individuals. In this study, we ended up with 19 in both the control group and the intervention group. It was the same exact design as we used before. And we saw very similar outcomes in the medical outcomes that I showed you before. The preventable conditions that we were trying to target went down in the intervention group. Those are the ones on the top. On the bottom, we see the control group where the outcomes either improved slightly, stayed the same, or got worse. And we did have a statistically significant finding in this group where we had a significant reduction in the number of UTIs that we saw in the intervention group. And we estimated a number needed to treat of just over 2, which means for every 2 people that used the mobile health system, we prevented 1 UTI. We also conducted a number of accessibility studies, which Laming will talk a little bit about after me, but I'll briefly touch on these. So we've enrolled people with spina bifida and spinal cord injury who have a variety of cognitive, motor, visual, and tactile impairments, and we evaluated the system for accessibility problems, made iterative improvements, and then looked at accessibility again, and we targeted 6 different areas of accessibility and had improvements in all of those areas after we applied those accessibility features. And some of the themes for the accessibility changes that we made over the course of this time were simplifying words and reading level, improving visual contrast, so certain words appear better against certain colors. Also, embedding instructions either in words or in icons to allow navigation to be easier as people move through the app so it's more intuitive. Giving the user the ability to change target size. Thematic colors, so when apps become more complex, people want to know where they are inside the app, and so if there's different modules, the users wanted thematic colors to be able to keep track of where they were. And also being able to control things like the camera in more than one way. Touching the screen is great for some people. Some people want to use the button on the side of the phone to control the camera. We've also, over time, conducted many user-centered designs, studies which were in the form of either focus groups or in laboratory testing. There were a total of 5 studies and over 150 subjects in total. And these involved both children and adults. We looked at people with a wide variety of functional needs and abilities. These were people with various disabilities, not just spina bifida and spinal cord injury, but other conditions like cerebral palsy. We also included health professionals and support personnel and families, including a focus group with a community-based organization that serves people with disabilities. And we've identified 23 major usability issues that we address through iterative development changes. And to just summarize some of those important themes, some of basically the participants tell us that, to make the system easy. They don't want it to be complicated. They want it to be engaging so that if we expect people to use it for long periods of time, which we may for people with disabilities, it's got to be engaging to use. People want to be educated and prepared. They want us to motivate them, but support them in the care that we're delivering. They want plug-and-play modules, meaning if you don't need support for your bladder management or you don't need support for bowel management, you don't get those modules. If you do have issues with mood or you do need to manage your medication, you do get those modules. So people can sort of plug and play the things that they want. And over time, that may change. So some people may use a module for a while and then not use it for a while. Again, they wanted easier simplification, reading level, and the ability to personalize. So it was really important to participants, especially kids, to be able to add unique backgrounds, their own avatars and icons. So all that being said, this is what version 2.0 looks like. Completely different user experience with the interface, all based on user input. Also, what is a new feature in 2.0 is that we added an interface for a caregiver. So that caregiver could be a parent. It also could be a paid caregiver, like an attendant care individual. It could be a parent who's acting in the attendant care role. And also the web-based clinician portal could also be used by a non-clinical person, such as somebody at a community-based organization. The new app was also cross-platform. So in our early studies, it was only Android. This new version is across all devices. We made the app suite adaptable. So from the perspective of the portal, you can see the person managing a cohort of people can just go in and for each person easily click boxes for the features that they want the person to receive on their phone, and those will synchronize automatically. Just to walk you through a few of the highlights of how the apps look now in our new version. This is the medication app that allows the person to get reminders to take their medications and indicate to us whether they did. This is an app that allows them to get reminders to check their skin for pressure ulcers, and then if they have a problem, they can report it either by taking a picture and uploading it, and also providing descriptive information about the wound. Many of our patients have bladder issues and are on catheterization protocols, so this app allows them to remember to do their catheterization every few hours. And similarly, manage their bowels through a bowel program. There's a mood app that surveys them on symptoms. In the current version, we're using the PHQ-2 and the GAD-2 for depressive and anxiety symptoms. What we found in our prior work was that goal setting was very important, and that was what helped engage patients. So we have a goal-setting app where patients can keep track of their own wellness goals and then also keep track of how well they're doing with those goals. And these goals can be monitored then by the clinician or caregiver who can give the person feedback or encouragement. We also created a very large database of educational material for a lot of the medical issues that are very disability specific that may not really be available to our patients, and they have a hard time finding. All of this information is completely customizable, and we spent a long time making sure that the navigation was acceptable to the participants, and also that the reading level was appropriate. That we've also been developing quizzes at the end of all the modules so that we can test their ability to understand it. We developed a personal health record, which allows the person to keep track of a whole lot of different issues that they've had in the past, and if they end up in the emergency room, they can have that right in their pocket. Exercise is something that's really important, and in particular, adaptive exercise. So we gave the ability for the user to report how much they're exercising and what types of exercises with a whole database of accessible activities. Nutrition, like exercise, could be very complicated, and what we've learned with developing these two modules is that, listen to the users, and simplicity is best. People don't want to log every single food that they eat in the whole day. And so we've focused our nutrition module on My Plate, which is understanding portion size and how many servings of different types of foods people should eat during a day. And this allows them to tell whether they're meeting or falling below those recommendations. And it can be customized for individual needs. Many of our patients, some of these aren't showing up, I apologize, but some of these, a lot of our patients use wheelchairs, and so they need to understand the importance of wheelchair maintenance and the process that they go through to get a wheelchair, which can be very complex, and this app navigates them through that process. One of the things I mentioned earlier too was that rewards and gamification was something that we've embedded in the system. We want the ability for the users to be able to be engaged, earn points for things that they're doing, and then be able to convert those points into personalization. So using those points to change the look and feel of their app as they earn more points. It could also be used in other ways. And then also we have thumbs up, where clinicians or caregivers can give encouragement and tell the user that they're doing a good job. We have secure messaging, which allows secure text-like messaging embedded within the system between and among the different users. a contact list, and also an app to allow the patient to manage the supplies that they're using. And again, just like the modules themselves, the educational materials can all be deployed individually whenever the person monitoring them wants them to receive that information, or whenever the patient wants to receive it. It can be completely customized. And to just give you an idea, these are all the different educational modules that we developed. So we spent a lot of time on those. Finally, what I wanted to talk a little bit about was supporting community-based organizations. So what you saw was just the beginning of what we developed. What I described so far is more of a medical model where we're following a person in the clinic, or we're helping them manage medical problems at home, but we also realize that community-based organizations may be a different model of care through mobile health. And so we've partnered with a local community-based organization that helps people stay active and independent in the community. And they wanted basically to be able to use mobile health to support a lot of the programs that they offer. And what we saw was that the case managers who worked in that program would basically lug big suitcases around with them with all kinds of binders and paper-based forms. And we said, give us all of those. Let us figure out how to convert those into a mobile health system. And we looked at all of those and came up with some themes. And so some of the themes that we realized that they wanted was being able to allow the person to keep track of their daily activities, so what they need to do throughout the day. Let's say they need to do laundry, they need to prepare for work, and then some of those activities need to be done by an attendant. So they want the person to learn self-management skills so that they can teach their attendant what they need help with. And so what we could do is create a list of activities for a person and also allow them to designate those activities to their caregiver. And then the caregiver can keep track of what they need to help the client with. They also want the attendant to be able to log their hours. They want people to be able to manage small pots of money that they have through waiver programs. They want support for work and school activities. Help with transportation was huge. So how do we coordinate appointments with transportation, which can be very complicated. So those were some of the other modules that we developed. And to just give you a quick glimpse of the transportation module is at the top. This allows them to distinguish between a regular transportation appointment or one for medical purposes. And then these can be linked to their appointments, and they'll get reminders that they need to schedule appointments or be able to keep track of where they would get picked up or dropped off. And the bottom is the daily activity management module, which allows them to keep track of the activities and who needs to help them with which. And again, there's an interface for the caregiver, and this is where the attendant can see what they need to help with and log the hours that they're helping the client with. So that's just a quick, fast overview of all of the development that we've done over the years. This technology will be in our showcase tonight, so please come by and you can interact with it and use it and see what it's like on different devices.
Thank you, Brad. So as Brad mentions, there's probably over 10 years worth of work in developing the I'm Here system. And in addition to being able to expand out to the community and providers outside of the medical community, we're also looking at the natural support system. So in Boston, because we've expanded this to as young as age 12, we'll be looking at how to use the system in conjunction with families. So as youth transition off to college or out of their homes, we'll be seeing how we can have family members act in that sort of caregiver role and support them remotely. So as we have continued to expand the populations that we're serving, we're also challenged with creating an app that is accessible to a wide variety of persons. And so Dr. Pramanto and Dr. Zhao will share some of those perspectives.
Okay. My name is Lamindro, and this is my colleague Andy. Septano. So we only have a few slides, so we will not switch. He will join during the discussion. This one we'll talk about the mHealth app accessibility and personalization. So Brad already covered the background and also mentioned quite a number of personalization. So it make our job much easier. So the personalization is actually very important for the accessibility because we know that there's people with many different types of disabilities and their needs are quite different, and then those disabilities are also in a spectrum, and then so we can use personalization to meet their needs. As we also hear from the first talk this afternoon, there are a huge number of mobile apps created in the past, but there is only a small number of them for people with disabilities, and even smaller number of apps specifically consider the accessibility part of those apps. So this basically makes it very difficult for people with disabilities to use those apps, and especially the ones trying to help them to manage their own health. And we know that people with spina bifida, cerebral palsy, spinal cord injury, they typically have issues like motor, cognitive, and vision impairments. So this study is to evaluate and improve the accessibility of a mobile app. And for this particular one, is mHealth 2.0, and this is for people with CPSB or SCI. And also we're trying to see whether our approach can be generalized and applied to other apps. And the solution is a universal cloud-based accessibility and personalization framework. And so this, so from this one, basically, we do the personalization in this setting page of the mHealth 2.0. So in addition to they can select those personal profiles, they also can choose different color themes, and those color themes has different contrast, and also for they can choose the different text size, the button size, the spacing between buttons, and also for some people with disabilities, they probably can only use one hand, either left hand or right hand. So then we actually can allow them to switch the positions of buttons. So this one is initially was on the right hand side and can be switched to the left hand side. And this is some examples. So after you apply different color themes, and then you'll see the difference. So some of them is basically personal preferences, but other ones actually can improve the contrast of those texts. And also from this, you can see the difference when you increase the size of the font and also the spacing between those buttons. And also this one, this is the education part, and then you can see the difference. And also this part is for the skincare module. So for people with disabilities, especially like if they have fine motor issues, it's very difficult for them to enter, use the keyboard to type things. And so when they report their skin issues, they do not need to type any words. They can just choose one specific part of the body, and then the information will be entered. And even like the situation of the wound, they also can just choose from a few questions. So it'll make it much easier for them. And also, all this personalization and selections done by those users are stored in a cloud server. So they, because in these days, those users typically using multiple devices. So after they make the selection on one device, it will be synchronized on all other devices. So if they they log into multiple devices, they will see the synchronization immediately. Or if they're not logged in, they can log in and then they will see the changes. So to evaluate whether this approach actually works or not, so we recruit 5 subjects, and this is 3 of them are female and 2 of them are male, and 4 of them are have cerebral palsy. One has a spinal cord injury, and they all wheelchair users, and 4 of them actually need dedicated caregivers, and 1 is relatively independent. 3 of them actually have below than normal cognitive capability, and they have moderate to severe dexterity impairment. And we asked them to use the I'm Here 2.0 without the accessibility feature, and they actually can use that. But for some specific modules, they do have difficulties. They can use, but with some difficulties. And then after we turn on the accessibility feature and they make the selection, it becomes much easier for them to use the app. And so it basically means using the personalization and those accessibility features will improve the accessibility of the app, even for people with moderate or severe impairment. And this actually, we are creating a standard so that if other people follow the same way to create the mobile app, they can also use this framework on their own app and make it accessible. And we also tested, during the study, we tested the other available accessibility features offered by the operating system and hardware. So for example, the Bluetooth joystick, it can pair it with the app, and also can use and improve the accessibility. And also the user can use VoiceOver to hear the content of the education and on other content on the app. So we have a short video. Okay, so this one, the first person, this is our participant number 3. She can only use her left-hand side, and when the button is at the right bottom corner, she actually had difficulties to click the button. After we switch that to the left-hand side, you see it's much easier for her. And then this is the next one. So this is like a compare. This is the same person. This is with the accessibility feature and without the accessibility feature. And you can see that without the accessibility feature, it was much harder for her. And this one is on a tablet. So the tablet sometimes can make some app more accessible, but not always. So you see, still, like if you turn on the accessibility feature, it'll be much easier for her to use the app. And this one is paired with the joystick, and she can make selections much easier than like using her hand. And this one is about the synchronization. So like if you make changes on one device, and you'll be synchronized on all. This is turn on and off the accessibility features. And if you change the size, and you'll be applied onto all of them. Yeah.
That's all for our presentation.
Okay, and so lastly, Dave Brennan is going to share with us the perspectives on how to integrate this within a healthcare system.
Thank you for saying how to integrate this, because if we had figured it out, we'd all be in a much better place. So thanks for having me. When I was invited from these guys who I've known for quite some time, at first I was a little concerned that my perspective might not fit, and listening to the previous 3 presentations, I'm still not convinced it does, but I'm hoping that I can give you guys a little bit of insight going into the break, because I think it's actually a good segue into some of the topics we'll be covering in the next section. My name is David Brennan. I work for MedStar Health. How many folks in the audience are kind of regional, like live around here, that recognize the brand of MedStar? Okay, not too many, so I'll give a quick overview of that. But I will start with my, you may remember me from, I was actually in the first RERC on telerehab. That was at National Rehab and Catholic University. So that's me with a full head of hair almost 20 years ago, as funny as that is. And I put this picture up here, this next graphic, which was probably a slide I gave at a RESNA meeting in like 2000, only because what I find so interesting is when we got this RERC in 1999, this whole notion of access and mobility, like we had to fight tooth and nail with some of the folks from NIDR at the time, some of which may be even in the room, so my apologies. That mobility at the time and access wasn't a rural issue. They couldn't really fathom the fact that a grant on telemedicine, telerehabilitation would be given to a group that was in Washington, D.C. Like their thought was this had to be an urban access issue. And our perspective, and it still rings true today, is that disability, if anything, makes access, you know, what I said at the time, if you rely on metro access and a cab to get you from a 4-story walk up to the hospital a mile away, you might as well live in a farm. And I think that's kind of true today. So I'll just take you back real quick from my perspective. So MedStar Health is the largest healthcare system in the Baltimore, D.C. region. By finances, about close to $6 billion nonprofit health system. But we're large. We have 10 big brick and mortar hospitals, like every large healthcare system. This is really what our focus was. This is what healthcare was many years ago. You owned a lot of beds, a lot of brick and mortar. Increasingly, however, this is really what MedStar is now. In 10 years, we grew from less than 100 care sites to now we have over 280. National Rehab Hospital is our rehab flagship home right in downtown DC. The Regional Rehab Network has over 50 outpatient therapy sites. So we really see everyone from big box ambulatory sites to walk-in clinics to retail clinics, outpatient surgical centers, but we also do quite a bit of home care. We have the area's largest V&A home health service. We have a home-based geriatrics program. So we're really everywhere. So when I put this map up there, especially for the folks in this audience and at this conference, our sites of care are really everybody's home. And that's sort of the journey that we're traveling on together. Skip through my old time. This is sort of the landscape. This is the changing healthcare landscape we all work in. I wrote a quote down here, so I'm glad you said how to integrate this stuff. Depending on your career trajectory, it's either an enviable or an unenviable swap from me trading my research hat to a clinical program development hat. Because healthcare is ridiculously complex. Like, we still can't convince Medicare that they'll reimburse for care delivery to a patient at home if they're in an urban area. Medicare still doesn't pay for this. This has been 25 going on 30 years. This is absolutely crazy. But healthcare as a whole is switching from the bottom to the top, where care is getting not just how it's delivered, but how it's paid for in a more coordinated fashion. Finally getting some compensation for providers thinking more proactively. Some of the great applications we saw here before, like this challenge of going from research to applied clinical services, is all about who's going to pay for it, right? I have no shortage of vendors who knock on our door at our Innovation Institute and say, hey, I got a great app for a great patient population, you should be doing this. And I love it, they love it, but when I take it to a hospital chair or a department chair, once we get into that brass tacks discussion of, okay, what happens when the pilot runs out? Can't get it paid for. This is criminal. Unfortunately, this is the world we live in. So as a system, as all of our systems, we're trying to come up with creative solutions to make this transition happen, enabled by technology. So this is sort of my mantra. I've been saying this, I should have trademarked this years ago, move information, not people. Like, to me, this is telemedicine, mobile health. This is all about the delivery of care and the transfer of information. And it changes how we deliver care. That first graphic I put, so when I got my start in telerehab, I was very fortunate enough to get paired with an amazing group of speech therapists, published quite a bit of manuscripts. We got a number of grants. We rode that for about 10 or 15 years, doing really, really good, what I thought was applied research, and it was a good applied research. couldn't really translate it into a clinical program. It's something we're still struggling with. But it was all about that craziness of this is an interaction where, for the most part, a therapist and a patient are not hands-on. They're interacting with each other verbally over a computer, oftentimes sitting in front of a computer. So let's just have you on your computer at home and me and my computer at office, right? 20 years later, we're still struggling with how to make this work. So in response to this challenge and the opportunity, our center finally, our hospital system finally, last spring, really anteed up. We now have a group of 6 full-time employees, hiring a couple more, trying to take this beyond concept and really make it stick and put it at scale. Even if you look at some of the large systems, MGH, phenomenal telehealth program. I know the folks up at Partners really well. No large health systems have massive teams devoted to this care transformation. And we've said all along, like if we do our jobs right, telemedicine and telehealth is just medicine and health. And I want to stop saying it and just say that's the reality. We're going to get there. So I'll give you a quick sort of landscape of the type of projects that, that we're doing. And the reason I put this up here is because I was writing in response to some of the things I was hearing before. I think the technologies, some of the mobile apps, the video apps, all of these things we're hearing about can really be, in my mind, sort of lumped into 3 main types of tools. Communication tools, care delivery tools, or care management tools. And what we're really tasked with at our system level is trying to put in these tools that we can scale across opportunities. And I'll walk through a couple of them real quick. But something like a provider-to-provider teleconsult, right? Most of us have heard or seen videos of telestroke. So a rural hospital without a vascular neurologist, patient in that bed can have a video cart wheeled to the bedside. Suddenly the vascular neuro is right at the bedside. This is cookie cutter. It's been going on forever. I heard you say MD Live before. Perfect example of consumer to provider. I have an app on my phone that says, I need urgent care now. I just have it on my phone. Right? I need a behavioral health coach, I need a vocational coach, I need a rehab counselor, a speech therapist. Once you have that app on your phone, who's at the other end of the line is just a matter of building out the clinical capacity. Provider director of virtual visits sort of flips that on its head, right? At MedStar, we partnered with American Well, not to name drop, just a competitor to MD Live. There's 4 or 5 of these big brands. The same tool that our patients can use to say, hey, I need care now, that tool now allows us to do scheduled outpatient visits. So we're starting with something really, really basic, perisurgical. So a post-op visit that is covered under a global payment model. Instead of bringing that patient in if they meet a certain number of criteria, patient gets a scheduled visit, they log in on their phone, nobody leaves their house, makes things a whole heck of a lot better. So when we talk about, our moderator said before, and we talked about empowerment, and the words I heard were respect, choice, control. These are all things we want to give patients the ability to do through the technology that they own. And then finally, remote care management, which I think is really the sweet spot. Some of the things that you guys are working on here are I mean, a great lit review up front. The second application we heard, like I want that vendor knocking on my door. I'm not, we should talk. But really full-featured, full-powered programs. So just a couple of gratuitous screenshots for our system. In the top left, that's the prototypical sort of telestroke example of what we're doing. On the bottom left, that's our brand. We call it MedStar eVisit, but most large health systems have this. I know UPMC uses American Well. Also, there's other regional providers doing different systems as well. On the bottom right, that's an example of a teletriage system. We have a bunkered ED physician that can do rapid triage of patients as they come into our ED clinics. And then in the top right, where I really think we have so much opportunity, and it's fertile, just unexplored territory, this put the device into patients' home as a means for them to have a lot more self-autonomy and self-care capability. The wonderful woman at the top there was one of our palliative care patients. We still have a palliative care program that use a deployed tablet-based system working with a vendor. Device comes to the home. It's the same device we use for our CHF patients. The palliative patient without CHF doesn't need a scale, so we don't give her a scale. But that tablet is her lifeline of answering some questions, getting feedback, getting information to her care manager, to her care team, also allows them to do live video visits with her. Gentleman at the bottom might be enrolled in a more care management program for a chronic condition, be it diabetes or CHF or hypertension. So that's sort of the suite of things we're talking about. In the mobile space specifically, I don't have examples of here up. That's sort of managed by our digital health team. We were one of the first health systems to partner with Uber to try to do kind of speed the efficiency of getting rides. Whether or not that's mHealth, I don't know. We're working on better options for remote check-ins, pre-paperwork through your apps. Care management is still something, honestly, I think we're struggling with how to deploy. But just trying to get more. We do everything as consumers, but as health, we're still patients, and we have to really switch that. So a couple quick lessons learned from our work, and then maybe we can actually get. I think we might finish on time. I'm excited. So some of the things we found, and this is a lot of this rings true to me as somebody who spent a lot of my life as a researcher and even doing a lot of development of technologies. Pilots are the really, really easy things to do, and increasingly they've gotten almost way too easy. What a guy or a gal in the basement can hack together on a mobile app, a truly transformative application that by the time it gets to us, we're clamoring for it. It's really easy for us to launch it, but it's hard for these vendors to really get something that's going to stick. And a lot of it's payment, a lot of it's other issues. But for us, it's viewing failure as a success. Easy for me to say, hard for the CFO to buy. But when things fail, we've got to really learn from that. I mean, we've got a lot of clinical programs we started. Everything was great, never enrolled a single patient because it was like, oh, well, the scheduler never bought into it. Okay, well, identify that obstacle, haven't made that mistake again. Know the difference between strategy and tactics. Again, strategy is a long-term vision. Strategy is picking a vendor, or sorry, tactics is picking a vendor. Strategy is knowing what you're going to do with them. This one, particularly for this audience, end user engagement and training cannot be understated. When I left my world of kind of biomedical engineering background and applied researcher and went into the clinical side of things, people don't think about this. They don't think about, iterative, let's bring them back in and stick an actual user in front of the device. Like, it blows my mind, especially vendors. Like, every startup company I talk to, like, who's done your testing? It's crazy. And finally, there's no right way to measure return on investment. People say this to us all the time. Our sort of the MedStar mantra of best patient experience, best patient to work, or best place to work, we have 5 or 6 of those. When we evaluate the ability to deploy an app, build a care strategy, come up with a patient outreach approach, some of those are completely an access play. Some of them might be driven by a financial incentive. Some of them might be, we're going to give away every single one of those patient encounters because it's the right thing to do. And right now, that's where a lot of these things fall, right? We would rather the patients, now, we have things with readmission penalties and well, we have to manage them for sort of punitive measures, carrot and stick approaches. But at the end of the day, it's find what matters most to who matters most and focus on that. I love when the who is the patient and the caregivers, but it's really this whole kind of giant gestalt thing. I wrote one other point that I thought was salient and relevant. Oh, and then the last thing I will say for this, at the end of all of these, and I saw like for the app you had and all of these different products that are out there, they ultimately, so adoption is huge. People have to use it. People have to want to use it. But even more importantly in healthcare, it's building the clinical backstop, right? Like we can build the world's best triage solution. We're going through a lot of ideation with the behavioral health folks now. They want to do crisis intervention in the ED. And they're struggling with, well, when we start, we're only going to be in 2 EDs. How many calls is that service going to get? Well, we can't justify somebody full-time for that position if it's only 4 calls a day. Well, it's chicken or an egg at this point, right? So if we can create enough mass utility and get a dedicated clinical resource, in some cases, if you build it, they definitely will come. So that's kind of where we are. And then finally, at the end of the day, this is all about technology, but this is really what healthcare is about. So we can have the best apps and the best devices and all of this, but unless it's facilitating a better way to communicate between people, we're kind of doing this for no good reason at all. 3:09. You have 1 minute. Good.
So the next 5 minutes are dedicated to a break, but maybe because we have our snacks right here in the room, perhaps we can also open it up to questions for our panelists. And I wanted to point out, sure. Dave, that I spent 5 years of my life trying to commercialize the I'm Here mobile health system. It wasn't a wasted 5 years by any means, but even when the technology is fantastic, there still are so many barriers in our current healthcare system, but I think a lot of that is finally beginning to change. So are there any questions that people would like to ask any of our panelists while feel free at the same time to help yourself or oh, yes, yes, that's right. I almost forgot. Is this the correct code for this workshop? Yes. Okay. CEUs, right? That's what that code's for? Okay. Here we have a question. It is not yet commercially available at this point in time. Yeah, it's still in research and development. So I think folks will be about in case people want to approach anybody for questions, but thank you.